Okay, so Emmanuel, that is the case. Please read the case aloud, and then I will give you the time, and then we go from there. We go from there. So
Okay.
read the case.
You are on an ER call rotation with a neurosurgical team today. A 52-year female is rushed to the ER by the local ambulance team with her. She is unresponsive with a GCS of 3/15. She is unresponsive after a fall from the 7th floor of a building. She still, however, remains intubated, and a quick assessment indicates that her pupils are fixed and dilated. The neurosurgeon who was consulted informs you that patients will not make it. You are informed that the patient's only daughter will like to speak to you about the situation. Counsel her.
Awesome.
8 minutes.
So Emmanuel, use 1 minute to prepare your mind, and then we'll use 8 minutes to get into a nice banter. Let's go. So 1 minute has started, and then we'll take it from there. Okay. Emmanuel, your time is up. Please come into the room and let's have a discussion.
Okay. Can I start now?
Yes, please.
Okay. Good morning, my physician examiner. My candidate code is 0123. Hello. My name is Dr. Emmanuel. I'm the physician in charge today. How may I help you, please?
Doctor, I'm called Mary.
You have what?
Mary. I'm called Mary. Mary.
Mary.
Yeah.
Can you please confirm your age for me?
Doctor, I'm 25 years old.
Okay. And your relationship with the patient?
Doctor, that is my only father. He is my father. I'm her only daughter.
Yeah, I'm sorry to hear about the situation that happened. We have been trying our best since admission to make sure that we are able to do our best for your dad. However, so far, we have been able to reach out to the neurosurgical team who told us that there are certain concerns, and I'm here to discuss the concerns with you. May I go ahead?
Well, sure, doctor. Yeah, let's have a discussion about it.
Okay, this is my consulting room, and I want to assure you that there's privacy here. And however, looking at the room, would you like me to make any adjustments for you before we go ahead?
No, doctor, I'm fine. Let's go on.
Okay. You have been aware of everything that has been happening concerning your dad in the past 24 hours. Can you please tell me what you know so far?
Oh, doctor, I don't know where to start from. This is so difficult for me. He's my dad. I love him. And I was called by my auntie that he had gone visiting, and unknown to her, he said he was just checking something out. Apparently, he went on top of the building, and I was told that he was brought here because he fell from the building.
I'm sorry to hear about that. I can imagine that must have been quite destabilizing for you and the family.
Yes, doctor, it's too tough. I don't know what is happening to my dad now.
Yeah, we've been trying our best. While I cannot give an assurance of how this may eventually end, I might be able to give you some information that can help you and prepare your mind.
Okay.
So, going forward in our discussion, you've told me that the incident that happened, looking at his care, can you tell me what you think might be the eventual outcome?
Oh, doctor, I don't know. I really, he's my only dad. He's all I've got. I really want him to be alive. But, I'm not a medical person. Doctor, can you, save me the trouble and let me know exactly what is going on?
Okay. Following our discussion with the neurosurgical team, they are the specialists in charge of this situation. I have been informed by the surgeon in charge that this has led to a situation whereby he's not conscious. That's the first thing, and he's no longer responding to touch, no longer responding to his name, as you can see.
So, doctor, does that mean my father has died?
Oh, Mary, he has not died. because we have to be able to carry out some other physical examinations on him to know. However, according to local laws, at the state where he is now, he can be called being brain dead, as he's no longer responding to all these things, and his GCS is 3/15. That is the lowest it could be. However, this is not an all-gone situation. Anything could still happen. Are you with me?
Yes, doctor, I'm with you.
Can I offer you this tissue paper for you to clear your tears?
Well, thank you, doctor. Okay.
Yeah. I could as well give you a minute for you to take in the emotions. Is that okay for you?
Well, doctor, that's fine with me.
Okay. Before we go, is there do you want me to invite any other person to this discussion?
Well, doctor, none of our other family members are around apart from my auntie whom he visited, and my auntie is disabled. She's in bed, so she can't be here.
Okay. So this is the situation right now. Is not responding to treatment, and the neurosurgeon is of the opinion that we begin to prepare our minds for anything that could happen. However, we will continue to do our best possible to ensure that he gets the best care and we get the best outcome at the end of the day. Okay. Looking at this, is there any information that you feel I've left out?
No, doctor, you continue.
Okay. All right. So this is what has happened, and this is what is this is the situation right now. Do you want me to inform any other person apart from you in the family?
Doctor, you continue. You continue.
Okay. All right. Thank you for the time. Do you have any questions so far from all we have discussed?
So does that mean you're going to stop his life support?
Okay. Thank you very much for the question you asked. Like I said earlier, I'm going to clarify your question. I said earlier that we are doing what we will do. We'll continue to do our best while he's still with us. But I'm only discussing this with you to prepare your mind to know where he is right now and the prognosis, what may happen. However, we do not pray that that happens, but we'll continue to do our best to give you and hope for the best outcome possible.
Doctor, he's been here for 24 hours. He's not doing well. What is the outcome? What's the final outcome? Because I heard you that you said the neurosurgeon said he's not going to make it.
Unfortunately, we cannot make that kind of categorical statement at this point, and we'll continue to do our best to see if he could actually still make it. However, he's at the point whereby he's classified as being brain dead.
Okay. So what does that mean, doctor? Does that mean I'll have to bury my dad? What does that mean?
Being brain dead, again, according to local laws, is the definition of death. Okay. And at this point, unfortunately, with all the things we have done so far, we have not been able to bring him back. I'm sorry to offer this kind of news for you.
Oh, okay.
Is there any other thing you would like to know concerning his care?
No, nothing really. Okay. I know when he was alive, he used to talk about being an organ donor. Is he still a good candidate for that?
Yes, those are the other things I wish to discuss with you. At this point, I would like to know if there are preparations that have been made before now as regards is there anyone that has been appointed as his surrogate decision maker?
I'm his surrogate decision maker, doctor.
Oh, okay. So at this point, you are legally able to dictate how his care goes, whether we could stop all cares, and in line with the patient, with his own personal views. That is, you are to tell us what he would do if he were alive to make the decision. What do you think you would like to do?
Well, my father doesn't like suffering. And so if, keeping the tube down his throat and everything is going to just prolong suffering and is not going to bring him back to his original life, then I might as well make a decision he would have made if he was here.
All right. So you think we could withdraw all care at this point?
Maybe, even though it's a very tough decision, doctor.
All right. Talking about the organ donation, do you know what decision he has made before now, and if there's a documentation to that effect?
I know he has a documentation with his lawyer, and it's also in his medical chart with his family doctor.
Okay, and he indicated that he wanted to donate his organs?
I think so, yes, doctor.
Okay, so I'm going to contact the organ donor network and they will have further discussion with you. Is that okay?
That's fine with me.
All right. Do you have any other concerns?
No, doctor. Doctor, your time is up.
Okay. Thank you.
How was it? No, let's talk. How was it? And then the class can also bring their input. How was it, Dr. Emmanuel? Just talk to me because you decided to step on the pedestal. So I'll give you the chance to have a conversation with me.
All right. Thank you very much for the opportunity to the case. I feel it wasn't a difficult case, but I'm not sure how I handled the case. So I started looking at spikes in family medicine in breaking the bad news to the patient, asking if he's the next of kin. And then I asked if the other family members are welcome to be invited in case the person is not able to bear the news alone. I also gave the patient some time to be able to bear him taking the news. Peradventure, I could also schedule another time, to discuss with the person in case he's not mentally ready. So after that, I went on to other parts of a patient's life at this time, because a patient who is dying and who is this old might have made certain decisions about his afterlife, his care in case he's not able to make decisions. So those are the other things I heard. I'm not sure I did however.
Well, so Dr. Emmanuel, I have this information from Dr. LP says, it was a great attempt. He touched on a lot of very key topics. Love the way Dr. Emmanuel showed empathy. That's true. He showed empathy. By the way, Dr. Emmanuel, which strategies did you use when you were showing empathy? Which strategies, like from the encounter you had with me, which strategies did you use before I go into my notes? And if anyone also wants to speak, they can let me know and then they can just unmute themselves when Dr. Emmanuel is done.
Okay, I had certain ways in which I try to counsel patients when I'm talking about a bad news. So I just followed that kind of plan.
Yeah. So what were your strategies?
Okay, the first one was to try to listen to the patient to see what they know and what's on their mind. And after that, try as much as possible to put myself in the patient's situation and offer supportive care while I give this information to the patient. And after that, them what more they would want, because I could understand that it can be a very difficult thing for patients to accept.
Exactly. Does anyone else have any contribution, concern, how maybe he went about it? Does anyone want to speak before I bring in my input? Any other person? Maybe let me start sharing my screen. Dr. Mano, thank you very much. That was very good.
Great.
Does somebody want to speak? Okay, so maybe if no one wants to speak, we'll just go ahead. So this is a very difficult case, as in not difficult in terms of the case itself, but difficult for the patient's relative, right? So you have to find ways of maybe, so Dr. Chikodili says he did very well, but I think he waited to be prompted to ask about organ donation. That is a very key one. In reality, I shouldn't have even told him, but just so that the case can move on smoothly. And this is just a learning curve. The exam is in October. We are now in July, so I don't want to hold people too close. That's why I threw that one in just to see the tangent. So, Dr. Emmanuel, in reality, you should have brought that discussion up, because this is end of life. We're talking about traumatic end of life. So, thank you very much, Dr. Chika. I'll just call you Dr. Chika. So like what Dr. Emmanuel did, you basically want to introduce yourself. I am Dr. Amubroni. I am the family doctor on call today. Is it possible for us to maybe go to a quiet place to have this discussion? Because the patient's daughter was introduced as being in the hospital's hallway. And Dr. Emmanuel did that. He took me to his consulting room and made sure that everything was quiet there. And then also inquire about whether or not she's ready to speak to you, which Dr. Emmanuel did, and he even gave me the caveat that, look, if you are not ready, what we can do is that I can schedule another time for us to talk about it. And then you also want to establish the reason for this urgent meeting. Why? Because this patient is brain dead. And because the patient is brain dead, you want to let the family know as quickly as possible so that if they have anything they want us to discuss in relation to whether organ donation, no organ donation, his end of life care, as he had already stated, then we deal with that. I think someone else has brought a concern. Let's see. He sees he did very well, but I think, okay, no other message has come through. Nice one. He did well. Having said that, not every physician is allowed to talk about organ donation unless especially trained for that. Otherwise, just transfer to organ procurement organization, member of staff. Well, that is true, but how do you transfer unless you've just brought the subject up? So like what Dr. Emmanuel did, he's not going to go, and that came from user. I'll use whoever is user. Thank you very much for that contribution. But as a family doctor, you can still ask. Even though you're not going to go into the discussion of it, you can still ask. And Dr. Emmanuel said that I'm going to allow those who are responsible for that to come in. So thank you for bringing that up. So you want to greet the patient and establish a reason for the urgent meeting. And of course, you want to use the spikes approach. And this time, what Dr. Emmanuel did was that he told me that, look, I'm going to send you to my consulting room. What we usually do in the hospital is that during some of these critical meetings, we don't do it alone. At times, you want to bring the nurse in, like the nurse in charge. You may also want to bring the social worker as well, because it's a team approach to discussing this particular issue. And then you also want to let the patient know, or let the patient see that, look, I'm all yours. I've given all my attention to you. So put off your phone and avoid all distractions. And don't be seen as being in a hurry. And one thing you can do as not to be seen in being in a hurry is to decide to sit down. You sit down, you don't look at your phone, you let the patient know that, look, maybe even though we are in the ER, my other colleague is taking care of it so that I can give you all my attention. Now, what is the perception? In other words, what do they know so far? Because look, don't assume that because you are the doctor, you are the only one who knows what exactly is going on. After all, everyone knows what happens if somebody falls from a 7-story building. Like the person may not be doing very well. So find out how much does the patient's daughter know? Like maybe she's even already thinking that, oh, maybe the father is dead, and maybe you are going to start a conversation from somewhere. When you know what she knows, it helps you to just know where to start from. And then now you invite her, the invitation, that is the eye for the spice. You invite her, that is, you break the news down in bits, piece by piece. So knowledge, demonstrate it, go direct, but in a soft tone, don't beat around the bush. You want to use very, very simple language, but language which is also easy to understand. And like the trick Dr. Emmanuel used, keep your cool, but make sure you are safe, because in situations like this, the person can be overcome by so much emotion that at times they can jump on you and maybe hold you, hold your clothes. So that is also something. While you are showing empathy, you want to make sure that you are safe. And then one thing you also want to do is the S is to summarize, where you are going to rephrase the patient or the family member's concerns. I put the patient's concern because at times you've done, or you've gotten a report of a biopsy, which indicates that the patient may have a hepatoma or something, and you are now going to break the news. So this is just the general view of how to break bad news. Now, take your time to know what the daughter already knows, as I said in the previous slide. And what were the circumstances around the fall? Was it like a suicidal attempt? Was it like, did he trip and fall? Just try to know it. Has he fallen in the past? Has that happened? What caused it? And how does the daughter feel about what has just happened? This is when you want to bring in the principle of fifing the patient, so this time it's not a patient who is almost dead, you're fifing, but a family member. Because at times you can also have caregiver fatigue, and that is something you want to pay attention about. How does the daughter you are talking about, how does she feel about everything which has just happened? And then what is her idea about what might have happened to the patient? Like I brought in, is my father dying? That is her idea. And then what is the daughter's expectation from the conversation? Because from this conversation, maybe I brought the issue of organ donor up. So that is something I was expecting. I also wanted to know, are you making a declaration that my father is dead? So that is piping the patient's daughter in a nice way. Now, the other things, I think Dr. Emmanuel talked about the substitute decision maker, but the concept of patient's advanced care directive should have been hinted on more. How does your father want to be treated in this situation? Does he want to remain on life support? Like, what does he really, really want us to do? He touched on it briefly, but I wish he could have gone in more. And then he also explored the support systems for the daughter, which is very important because he asked me, are there any other people you want me to invite? And I told him that it's my auntie, but she's bedridden in some long-term care facility, so she cannot come. So Dr. Emmanuel offered that, but the patient did not have that kind of support to call on. And one other thing, because she is also like making a decision for the dad, you also want to find out any coping mechanisms she has in place for the situation. Because if you don't find out, she may also be overwhelmed. I met a similar case. A patient came to the emergency room. Recently, husband has been shot. Father was isolating in a house, and the house got burnt, and father died. The day before I saw her, she had to file a missing persons report on mother. And then while I was talking to her, I just left the room in the emergency room to go and deal with something. She had a phone call from the RCMP. And the way the RCMP put it was that we need to come and speak to you about your mother. When this happened, I was like, no, this patient can't go home. And I had to get a psychiatrist to come in. The psychiatrist literally had to admit this patient because he felt that the patient was too overwhelmed to take all this news in. And this patient may go home and just do herself in or even kill herself as well. So that is something we shouldn't think that everybody will just take all this information and just go home smiling. No. And any laid out end of life wishes expressed by the patient before the event happened, so like the organ donation thing we talked about, and has the patient in the past expressed any willingness about organ donation? So Dr. Emmanuel, that is what I wanted you to bring into the discussion, right? Which others have pointed out. Now, if the daughter is pushing that you must reassess your assessment of the patient's diagnosis and prognosis, you've got to reassure her, because I brought that up and Dr. Emmanuel went back to, in the provincial law, and the neurosurgeon has seen. So assure her about the certainty of the diagnosis and the prognosis. And I'm very happy that when I pushed him, finally he said that your father is brain dead. And then take your time to elaborate on why life support will not help, even if it continues. I think someone else has put up, please, can you give examples of coping mechanisms we can ask for specifically? So coping mechanisms, basically, does the patient know how to, deep breathing? Does the patient know how to, get herself or her mind out of the situation? Even some principles of cognitive behavioral therapy, which you can just talk to the patient briefly about. Just quick ones. You don't need to go so deep. Okay, so just ask, how have you dealt with past traumas? And the patient herself, or maybe I talk to friends, maybe I have a Facebook support group I join, or maybe I am part of the Lions Club in my community. So I'm going to call my Lions Club coordinator. Those things. The patient may even tell you, look, I do yoga, all those kinds of things. Okay. And then, even though the patient's father, the daughter's father is brain dead, because you have introduced the concept that continuing life support is not going to eventually help, the main thing is that you are going to extubate this man. When you extubate him, He's not gone yet. So you have to still talk about palliative end of life care and the fact that palliative care is active care. So it's not like you're going to take him off the life support and like you neglect him. But of course, when you take him off the life support, it will not take long for him to die. But you have to still let the daughter know that when I even take him off the life support, we are still going to, monitor certain things till natural death takes over. Okay, good. And then now introduce your plan if the patient is taking off life support. So, because now you're moving the patient or the daughter systematically through the system. So, the plan is that when we take him off life support, what it means is that we are going to take the tubes out, and then we're going to take the patient to a quiet room. And then you can offer to arrange for spiritual support if the daughter is open to it, depending on the patient's religious beliefs. So maybe if the patient is a Christian, you may want to get a priest. If the patient is a Muslim, depending on what the patient believes, bring in that as well to support the situation. Because who knows, people will get a lot of comfort when they get a religious leader coming in. Now, you've got to introduce the concept of organ donation based on the patient's current condition. He's brain dead. He had a traumatic injury. We can donate his kidneys. We can donate his this, his that, his that. So you want to introduce it to the daughter. And if the patient already has a wish that should happen, then you can have a conversation like what I rather introduce it to Dr. Emmanuel for us to have that discussion. And then offer your availability for a larger family meeting, because it could be that the patient's brother may want to fly in from BC, or the patient's sister who is in Vancouver has heard what has happened and she's already on her way. Don't just close this meeting saying that, okay, done, bye-bye, go your way. But then after you've talked to the daughter, you want to also let her know that, look, in case other family members come and it is difficult for you to explain what is going on, I am ready to meet with you again. You come across as a very, very empathetic person. This particular patient I talked about in real life, what happened was that when finally the RCMP called her that they would like to talk to her about her mother's situation. Of course, every adult knows when the RCMP knocks on your door, when you're looking for an adult, or when the army comes to your door with a flag and a cap about, a son who is in Afghanistan, you know what might have happened. So what she did was that she offered that her distant auntie would talk to the RCMP and take that burden off her. And you have to show your willingness to answer any unanswered questions, like what Dr. Emmanuel did. He was always invited. Do you have anything I need to clarify? Do you have anything I need to, throw more light on? And that really, really helps. Now, what are you expected to demonstrate? If you are following, just type following in the chat box so that I see that you are following, because I don't want it to just be a monologue. If you are following, just type in, I'm following. So in this particular case, what you're expected to do is that there must be loads, awesome. Hanan Samil says that I'm following. There must be loads of empathy, because this is a very, very troubling case. Loads and loads of empathy. You must be seen as being actively empathetic. Be seen to actively show patience, concerns, frustrations, and feelings. You are actively listening, acknowledging it. And you are doing that with good body language. And you're also doing that with simple, everyday language. You want to avoid a lot of medical jargon. In fact, Dr. Emmanuel did something. I've forgotten the word he used. But as soon as he used that word, he went on to explain it. So we are not saying don't ever use medical jargon. But in case you want to use it, so that it can be easier for you to communicate, as soon as you mention it, for example, hepatitis. Oh, hepatitis means inflammation of the liver, like something like that. You just want to explain so that the patient gets to appreciate it more. And use responses verbally and non-verbally. So encouraging the patient. There are times you as the doctor may have to keep silent and just allow the patient to speak. I think Dr. Alex said it in one of the webinars we had, or he said it in class, that look, if in the NAC exam you are seen as, using a monologue. You are the only one talking as a doctor. You are the only one talking. You are the only one talking. Chances are that you're not doing well. It should be a conversation. It shouldn't be a one-way street, you know? And then you must also use a principle of repetition. And you must use active listening skills. And some of the active listening skills are, you must be seen nodding your head. You must be seen looking straight into the patient's eyes. Of course, maybe the October exam, we don't know. It may be virtual. It may be in person. But you must be seen trying to engage the patient non-verbally by looking into their eyes. And give suggestions, not directives. So, with your father's situation, according to what the neurosurgeon has said, it is likely he may not come back to what he used to be. In fact, he is considered brain dead now. According to our medical practice, we may have to take him off life support. Is that okay? Rather than, your father is brain dead and so we need to take him off life support. That is paternalistic medical counseling approach. That ended before the Second World War. And don't bring that into your exam practice for the NAC OSCE. So you also have to have good posture and good gestures. And what you're expected to demonstrate, close the interview with a brief summary and a contract to the patient. That is the next step. This case, the next step is in case other family members come and they want us to, go into more details, I'm ready to have a conversation. And you must even be willing to offer to go to the bedside of the patient with a daughter so that daughter can have a better picture of what is actually going on. There are some traumatic situations where at times when you let the family come close to the situation, and you have to ask them before so that it doesn't overwhelm them. When you ask that, look, do you want to maybe come close? They may say yes. And you'll be surprised that after the patient visits the site, the patient may say that, look, doctor, I think we should go ahead and take the patient off life support. But what are the things to avoid? I talked about one of them. Avoid excessive medical jargon and technical terms. Use everyday language. In case a medical jargon slips out of your mouth, quickly explain and avoid cutting the patient off when they are speaking. Now, how do you hit the ball out of the park? Number one, you've got to be logical in your sequence. So how logical was your discussion with the patient from point 1 to point 2 to point 3? And did you use good signposting? When I say signposting, okay, so I want us to talk about maybe organ donation. I want us to have a conversation about whether your father had a substitute decision maker. And then the last but not the least is that you want to be seen paying good attention to timing. Good attention to timing. So just go ahead. So these are the things you need to do to really, really hit the ball out of the park, and in order to come out as a superior performer, a superior performer. And the only way you can feel, because in the exam you're advised not to take a watch, you will not see any watch on the wall, nothing. So the only way you can tell, I'm at the 8-minute mark, I'm at the 10-minute mark, I'm at the 11-minute mark, that the examiner is going to say, stop having a conversation, is when you practice to the extent that you understand what it means to be at the 8-minute mark, what it means to be at the 10-minute mark, what it means to be at the 11-minute mark. Only practice can get you there, especially when it comes to timing, because you can't have a watch. You are not going to have a watch on the wall. So how do you know? Your body must be able to tell you. And that is when you've practiced at least maybe 150 cases before your exam. Okay, so thank you very much for joining us today for this particular discussion. I had 2 great news today, 2 phone calls, and then 1 email. And the email went like this. It's a wonderful day. By the way, before I even go into that, I want to know if any other person has any concerns or question or contribution, please bring it up, and then let's try to wrap the class up. Please bring it up and let's try to wrap the class up.
Doctor, I was just wondering, this is LP here. So I was wondering if we can actually make the diagnosis of brain death here. I know he had fixed and dilated pupils, but a lot of times in trauma, especially, we wait for the neurologist or the neurosurgeon to definitely tell us it's brain death. Here, the neurologist just said that he might not make it, which is a very ambiguous statement. So that was my only concern in telling the patient that he's brain dead.
Oh,
Do you
sure.
think
Like,
it might be okay?
please finish. Please finish. Please.
No. So I was just wondering whether we could leave it as an open thing, that we could wait for some more time to see if there is any response, but I believe it looks bad right now. Can we just say something like that?
Sure. Yeah, you can leave it like that. You don't necessarily have to commit yourself to the fact that it's a brain death case. It looks very bad. The neurosurgeon has seen it. The neurosurgeon says he might not survive. You can leave it like that, just so that the conversation can go on. Yeah, you can leave it like that.
Okay.
Thank you very much, LP. All right.